Lucky to have Dr. Sally Baker presenting to us this morning. So Sally, take it away.
All right. Good morning, everyone. For those of you who don't know me, my name is Sally Baker, and I'm an R2 in our program. And my clinical and research interests focus primarily on infectious diseases, particularly in the immunologically vulnerable populations. And so today I'm going to discuss infections in the immunosuppressed population, delving into the immunological impact of immunomodulators. We're going to focus primarily on patients on immunomodulators rather than those with immune dysfunction in the setting of malignancy or HIV, because I think we get a really good overview of this in our curriculum already. And so by the end of this talk, I hope that you have developed a basic understanding of the specific classes of immunomodulators and their downstream effects on the immune response to infectious organisms. I hope you're able to recognize patients who may be at an increased risk of infection due to the use of immunomodulatory therapy, that you can appropriately implement indicated screening tests for infectious diseases prior to immunomodulatory therapy initiation, and that you can identify patients who require antimicrobial prophylaxis while on immunomodulatory therapy. Immunomodulators are a rapidly expanding class of medications that alter the host immune response, which is a complex network of cells and soluble mediators that comprise both the innate and the acquired arms of the immune system. Immunomodulators are used in the treatment of rheumatologic or autoimmune, neurologic, gastrointestinal, dermatologic, or oncologic diseases. And as a result, the population of patients who are immunosuppressed has grown considerably in our country. The increasingly widespread use and development of immunomodulators means that no matter what field of medicine you choose to practice, it is highly likely that you will encounter patients on immunomodulatory therapies, or that these medications may even become a mainstay of your treatment toolbox in the future. Let's begin by reviewing what constitutes an immunomodulator. These medications can be divided into 6 main groups. The first group are naturally occurring proteins or glycoproteins. These include medications such as colony-stimulating factors or CSFs, interferons, interleukins, and thymic hormones. Many of these are produced by recombinant DNA technology. Immunoglobulins, such as IVIG, are used either as replacement therapy in immunoglobulin deficient individuals or as true immunomodulators to upregulate or downregulate the immune response. Monoclonal antibodies, which are also produced in a laboratory, can block the action of cellular binding, cellular signaling, pro-inflammatory cytokines, or components of the complement cascade. GLUCOCORTICOIDS are immunomodulatory treatments that exert pleiotropic effects on components of both the innate and acquired immune systems. There are also synthetic compounds that we may not tend to think are classified as immunomodulators, and these actually include things like HMG-CoA reductase inhibitors or statins, pentoxifylline, and thalidomide. And then finally, there are immunomodulatory cell-based therapies, including mesenchymal stromal or stem cells. Today, we're going to focus primarily on naturally occurring proteins, monoclonal antibodies, and glucocorticoids, because these are the classes that we are going to see most commonly in patients we encounter in both the inpatient and in the outpatient setting. These immunomodulators act on many different aspects of the host immune response. And so to better understand the effects of immunomodulators on the host, let's review some of the basic immune responses to pathogens. This is going to be an incredibly basic overview. When the body encounters a pathogen, initially the innate immune response is enacted. Neutrophils begin to respond and proliferate, and the complement cascade is initiated. Antigen-presenting cells, such as dendritic cells, macrophages, present antigen to lymphocytes, and then those lymphocytes are able to mature and differentiate. Starting with one of the subsets of lymphocytes, B cells, they begin to differentiate and mature B cells express CD20 on their surface. Plasma B cells eventually begin to secrete antibodies, and antibodies can undergo class switching from IgM to IgG, IgA, IgD, and IgE. If you recall from your basic immunology, antibodies function in three main capacities: to neutralize pathogens, activate complement leading to pathogen lysis, and opsonize pathogens to facilitate phagocytosis. Each of these classes of antibodies plays a different role in the response to pathogens. IgM is the initial antibody that's secreted during initial immune response to pathogens. IgG is the most abundant in the body. IgA primarily protects mucosal surfaces, such as in the lung or the gut. And IgE is found on the surface of mast cells and basophils, and these contribute to the allergic response through the release of histamines. Upon antigen presentation in the immune response, T cells are the other subset of lymphocytes that begin to mature. And due to the production of a whole host of cytokines, they polarize into different T helper subsets, each of which produce characteristic cytokines and play different roles in protecting the host against pathogens. Starting out by talking about Th1 T cells, these are the subset of T cells that tend to disrupt intracellular pathogens. Th2 type C cells are associated with response to helminth infections, and Th17, which are my personal favorite, are one of the more recently identified T helper subsets. They are crucial for response to extracellular pathogens, such as extracellular bacteria like Pseudomonas, as well as including other ones that are associated with the pulmonary or gut mucosa. And Th17 type T cells also are important in the response to fungi. Once these cells are activated and differentiate, T cells actually can gain homing markers and begin to migrate to sites in the body where they can exert their immune response. And in many cases, this tends to be the gut or pulmonary mucosa. Now that we've reviewed the basic immune response to pathogens, we can better understand how immunomodulators either purposefully or inadvertently impact this response. We're going to start by talking about one of the most common classes of medications we incur in both the inpatient and in the outpatient setting, and those are glucocorticoids. Corticosteroids have inhibitory effects on a broad range of immune responses, particularly in patients who are on what we call moderate to high doses, which is a dose equivalent of greater than or equal to 20 milligrams of prednisone daily for 1 month or longer. Because of their inhibitory effects on multiple different types of immune cells that we're about to go over, glucocorticoids are remarkably efficacious in managing many disease manifestations of inflammatory and autoimmune disorders. These inhibitory effects are exerted on both the innate and on the acquired immune responses. And this results in a dose-dependent increase in the risk of infection, especially with the most common bacterial, viral, and fungal pathogens. Corticosteroids start by diffusing passively across the cellular membrane, and they bind to intracellular glucocorticoid receptors. And this results in the disruption of both gene transcription, as well as inhibition of post-translational events as well. Downstream, this results in the reduction in the formation of IL-1, IL-2, IL-6, tumor necrosis factor, and GM-CSF, which promotes the proliferation of monocytes and neutrophils. And in fact, corticosteroids inhibit the synthesis of almost all known inflammatory cytokines. Additionally, glucocorticoids inhibit the ability of the neutrophil to adhere to the vascular epithelium. And this results in that apparent neutrophilia that you might encounter when you see a patient started on glucocorticoids. But this also reduces the ability of the neutrophil to migrate to and respond to sites of infection. And at high doses, the neutrophil ability to phagocytose is actually also impaired. Glucocorticoids also inhibit the phagocytic function of macrophages, and they downregulate antigen presentation on the which is probably in part accounting for the reason that they affect the adaptive immune response as well. With prolonged glucocorticoid administration, the numbers of circulating B lymphocytes are reduced, and then also the levels of IgG and IgA in the body are decreased by between 10 and 20%. At higher doses, glucocorticoids produce a rapid depletion of most circulating B cells because they also inhibit IL-2, which is critical for the proliferation of all T cell subsets. They also actually impair release of T cells from lymphoid tissue. so they're unable to respond to infection, and they induce the apoptosis of T cells, again, contributing to the rapid depletion in this lymphocyte subset. From this overview, I hope that you can appreciate the increased infection risk with the use of glucocorticoids. This specific class of medications, just to review, includes many familiar names: prednisone, methylprednisolone, dexamethasone, and many others. And they have numerous indications across most types of chronic inflammatory diseases, including asthma, COPD, IBD, rheumatic diseases, as well as Graves' disease. It's important to remember that infection risk is directly related to the glucocorticoid dose, and the risk begins to normalize as soon as high dose therapy is complete. Infections that you should be on the lookout for as a physician include viral infections, particularly herpes zoster, because this occurs more commonly in patients on glucocorticoids, even at lower doses of just 7.5 milligrams per day. Patients are also at risk of common bacterial and fungal infections. And interestingly, reactivation of latent strongyloides infection can occur in patients receiving glucocorticoids. This can actually lead to a hyperinfection syndrome that can be fatal. And so this should be considered prior to initiation of glucocorticoids in any patient for a Helminth endemic region. Patients who are at an increased risk of infection in combination with their glucocorticoid use are those on concomitant immunosuppressive therapies. Patients with a previously identified lymphopenia, patients with diabetes are also at an increased risk of infection in the use of glucocorticoids. And then older patients with poor functional status have also been shown to be at an increased risk of infection. The other thing to keep in mind, particularly in hospitalized patients, is that patients on glucocorticoids may not manifest the same signs and symptoms of infection due to reduction in those inflammatory responses that we just went over. And this can impair early recognition of infection. So in patients on glucocorticoids, you should plan to hold live vaccines until at least a month after steroids are discontinued. The American Association for the Study of Liver Diseases recommends screening all patients on prolonged corticosteroids for hepatitis B virus. And then additionally, the big question that we get asked commonly is, should you consider prophylaxis against pneumocystis jirovecii or PJP pneumonia? Patients on chronic steroid use are a higher risk of PJP, and indeed the incidence of PJP is increasing, likely due to the increased prevalence of patients on steroids and other immunomodulators. So who should actually be on prophylaxis? So it's quite certain that patients on glucocorticoids plus a second immunosuppressive drug or plus another clear cause of immunocompromise, such as hematologic malignancies, should certainly be on PJP prophylaxis. But unfortunately, there are no guidelines for patients on glucocorticoids alone. But the thing I want you to keep in mind is that many of these autoimmune disorders, as well as other chronic inflammatory conditions for which steroids are indicated, also inherently disrupt the host immune response. And therefore, these patients may have an underlying immunocompromised state. And you should consider this carefully when starting a patient on a glucocorticoid for a long time, particularly 1 month or greater. One other thing I didn't mention that's really important to keep in mind is that there has been shown to be a disruption in the immune response on glucocorticoids in patients on shorter periods of time and even just short bursts. But it's more important to keep in mind that over a long period of time, these glucocorticoids disrupt the host immune response that we just went over. I'm going to take a second to pause for questions. Are there any in the chat box?
Yeah, there's a couple that have come up in the chat box that I'm happy to share. And then if anyone else has other questions, feel free to unmute yourself. There's a question, does the recommendation to screen for hepatitis B apply to those patients with previous hepatitis B serologies that show immunity?
Yes, so with patients on, once that show immunity, you should also be screening them, because we can talk a little bit later on about risk of reactivation. So if they've shown immunity from immunization, I think it should be okay. But if they show immunity from later on from a natural infection, you should be more concerned. And there are a few types of immunomodulators that we'll talk about a little bit in the future. But in terms of the specific recommendations, I would have to go back and check about what that means about immunization, but it should be okay.
And then the last question in here, another cause of immunocompromise, does this include diabetes, CKD, some of the other clinical entities that you mentioned already?
Yeah, I think that you certainly should consider that, particularly in diabetes. That one has been demonstrated to have an increased risk of infection in patients on glucocorticoids. If they have other types of underlying disorders that may inherently disrupt the host immune response, I would certainly consider putting a patient on PJP prophylaxis. Of course, those medications aren't without risk, but there aren't any clear guidelines about this, so it is left to your discretion, but I would consider it very carefully. Great. Thanks, guys. All right, so I don't know about you, but I am now sufficiently terrified of using steroids in my patients. So let's move on to another class of immunomodulators, monoclonal antibodies. Since 1985, approximately 100 monoclonal antibodies have been designated as drugs, and the rates of approval are rapidly increasing in the United States. There are now several different types of monoclonal antibodies on the market. And if you remember from your pharmacology, they're named in a specific convention according to the species of origin of the fragments of the antibody. So those with the suffix OMAB are derived from a murine source or a mouse source. IXMAB are chimeric and have variable regions that are of murine origin, and then constant regions that are of human origin. And then ZUMAB are mainly derived from a human source, and UMAB are entirely human in origin. So I'm going to start by talking about the monoclonal antibodies with the broadest reaching effects on the host immune response, and then we'll move into the more targeted monoclonals. I hope that when we go through these, you'll begin to appreciate that the more upstream in the immune response, the target of the monoclonal, the greater the impact on the host immune response overall, and the greater the risk of infection in those patients. There are many more monoclonal antibodies that I'm going to be able to highlight today, but I chose to discuss ones that we either use more commonly, the ones with a unique infection risk, or the ones that I think have really cool immunology. TNF inhibitors were one of the first groups of immunomodulatory agents to be recognized for their significant infection risk. TNF is an important pro-inflammatory cytokine. It's crucial for the formation and activation of macrophages, phagosomes, and granulomas, as well as the Th1 type T cell response. And so the inhibition of TNF predisposes patients to infection with intracellular pathogens and pathogens that are controlled by the immune system via sequestration into granulomas. These include infections with tuberculosis, bacterial sepsis, invasive fungal infections, and indications for these TNF inhibitors are very broad. They include rheumatoid, psoriatic, juvenile arthritis, psoriasis, ankylosing spondylitis, HS, uveitis, UC, Crohn's disease. So it's very likely that at some point in your career, you're going to see a patient on a TNF alpha inhibitor. So what do you need to do for these patients? The American College of Rheumatology recommends screening all patients for active or latent TB. And those with risk factors for TB who have an initial negative test should be rescreened 1 to 3 weeks after initial negative test to confirm that they actually are negative. Patients should also be screened for hepatitis B virus and hepatitis C virus. Another commonly used monoclonal antibody are the anti-CD20 antibodies. These antibodies ultimately result in B cell lysis and in B cell depletion. They're used both for patients with lymphomas and malignancies, as well as patients with rheumatoid arthritis. Patients on anti-CD20 treatment are particularly susceptible to many bacterial, fungal, and viral infections that are quite common. And then specifically, hepatitis B reactivation can occur and it may be fatal. And so it's actually interesting, rituximab carries an FDA box warning regarding the risk of fulminant hepatitis, hepatic failure, and death in patients who are on an anti-CD20 antibody. And this risk actually extends well beyond the completion of the treatment. Reactivation has been reported in patients up to 24 months after discontinuing rituximab. So all patients should be tested for hepatitis B surface antigen and hepatitis C antibody before initiation of therapy. And then those who are positive should be considered for antiviral therapy and monitored during and for several months after therapy with anti-CD20 antibodies. You should also know that fatal cases of PML have also been described in patients on anti-CD20 monoclonal antibodies, although it's less common. And the other specific things to keep in mind for patients who are on anti-CD20 monoclonal antibodies is that you should hold live vaccines until after therapy is complete and after the B-cell counts have been demonstrated to be recovered. The next monoclonal antibody I want to touch on is an anti-alpha-4 beta-7 integrin monoclonal antibody. So if you recall during my talk about the immune system, I mentioned that after activation, T cells gain homing markers that designate their migration to specific tissues, such as the gut. And alpha-4 beta-7 is one of those markers, and it directs T cells to the GI tract. Vedolizumab or Entyvio is such an antibody, and it binds to the alpha-4 beta-7 integrin and prevents its interaction with MAdCAM1, and therefore blocks the migration of these T cells into the GI tract. It's used for ulcerative colitis and Crohn's disease. And patients on this monoclonal antibody, as you would imagine, are susceptible to gut mucosal associated infections. And those include Salmonella, Giardia, CMV colitis, and anal abscesses. And then also susceptible to other infections that tend to be associated with other mucosal tissues, including upper respiratory infections, listeria, tuberculosis, as well as PML in these patients as well. All patients that are being started on vedolizumab should be screened for tuberculosis. And indeed, in all of the clinical trials of these medications, the patients were screened for TB. And then you should give live vaccines prior to therapy initiation if at all possible, although live vaccines are not a contraindication. So we've now covered monoclonal antibodies that target components of the adaptive immune response, including T cells and B cells. Let's move on a little bit to discuss a different aspect of the immune response, the complement cascade and the membrane attack complex, or the MAC. If you recall your complement cascade for a moment, you'll remember that there are a lot of C proteins that come together to form the membrane attack complex. And the downstream part of the membrane attack complex is formed by C5, which is then cleaved into C5a and C5b. C5b comes together to form that MAC, which then inserts itself into the wall of the pathogen and causes pathogen lysis. C5a is also cleaved from C5, and it mediates degranulation and phagocytosis by neutrophils. Eculizumab is an antibody that binds C5 so that it can't be divided into C5a and C5b. And as a result, it inhibits the formation of MAC and it reduces neutrophil degranulation. And as we actually see in patients with complement deficiency as normally, patients on this treatment are more susceptible to infection, particularly with encapsulated organisms. Indeed, there have been fatal cases of meningococcal infection that have occurred, as well as infections with strep pneumoniae and Haemophilus influenza type B. So in order to prevent infection, you should administer the appropriate vaccinations. In the case of the meningitis vaccine, it's recommended that you administer it at least 2 weeks prior to starting treatment. And if your patient is unable to be immunized against meningococcal meningitis, you should consider antimicrobial prophylaxis when starting a patient on an anti-C5 monoclonal antibody. Let's shift over to a different component of the immune response and to talk a little bit about anti-IgE monoclonal antibodies. Omalizumab binds IgE and it prevents its binding to the surface of mast cells and basophils. And this results in a decrease of the soluble mediators from those cells, such as histamines. For those reasons, it's used in treatment of severe asthma, as well as chronic idiopathic urticaria. And patients on anti-IgE monoclonal antibodies have an increased risk of viral infections and upper respiratory infections. And there's also been demonstrated to have a modest increase in new helminth infections. So you should assess for risk factors for helminth infections prior to initiating anti-IgE monoclonal antibody treatment. With a different mechanism of action, but also used for the treatment of asthma, mepolizumab is an anti-IL-5 antibody that binds IL-5 and prevents its binding to the IL-5 receptor on eosinophils, and this reduces eosinophil differentiation, activation, and survival. You might recall from the review of the immune response that IL-5 is a Th2 type cytokine. It's important for the response to parasitic infections. And indeed, known parasitic infection was an exclusion criteria for the clinical trials of anti-IL-5 monoclonal antibodies. So we actually don't know the impact on parasitic infections in patients who are started on these therapies. And so they should probably be treated for any known parasitic infections prior to the initiation of anti-IL-5 monoclonals. It's also been demonstrated that herpes zoster infections have been reported with mepolizumab, and so vaccination against VZV should be considered prior to initiation of anti-IL-5 treatment. Now that we're talking about interleukins, another monoclonal antibody directed at an interleukin are anti-IL-17 monoclonal antibodies. These are indicated for psoriasis, psoriatic arthritis, and ankylosing spondylitis. Th17 cells are crucial for the protection against extracellular pathogens, particularly at mucosal sites, such as the respiratory mucosa and the lung and the GI tract. And anti-IL-17 antibodies are able to reduce this response. And as such, patients are actually at an increased risk of upper respiratory infections, urinary tract infections, oral candidiasis, and there's actually also been one case reported of cryptococcal meningitis as well. As with many of the immunomodulators we have discussed so far, patients should be screened for tuberculosis. And regarding vaccination, live vaccines should be held while on treatment with an anti-IL-17 monoclonal antibody. If you choose to administer inactivated vaccines, do know that the response to the vaccine may be reduced, and it's something to keep in mind. The final anti-interleukin monoclonal antibody that I want to touch on today are anti-IL-6 antibodies. These are used for rheumatoid arthritis, giant cell arteritis, and juvenile arthritis. And anti-IL-6 antibodies bind to both soluble and membrane-bound IL-6 and inhibit all of its various pro-inflammatory functions, which include differentiation of TH2 and TH17 type CD4 positive T cells. These two T cell subsets are responsible combined for a protection against all sorts of pathogens. And so use of anti-IL-6 antibodies has been associated with life-threatening or fatal mycobacterial infections, other life-threatening or fatal bacterial infections, viral infections, disseminated fungal infections, including Candida, aspergillosis, Cryptococcus, and PJP. Other common infections also occur more frequently in patients on anti-IL-6 monoclonal antibodies, and these include upper respiratory infections, pneumonia, urinary tract infections, cellulitis, and herpes zoster. Prior to initiation of therapy with an anti-IL-6 monoclonal antibody, patients should be screened for tuberculosis, and very careful consideration should be given to the risk of using this agent in patients with risk factors. The other thing that you should know is there's also an antibody against the IL-6 receptor, so not against the interleukin, but against the receptor itself. And that has similar infection risks, but interestingly, it's also been shown to result in neutropenia in patients. So patients should be monitored for neutropenia every 3 months if they're on an anti-IL-6 receptor antibody. So we're focusing a lot on interleukins. So I want to move on to this final category of immunomodulators, naturally occurring proteins. We're going to talk about an IL-1 receptor antagonist called anakinra. It's used for patients on rheumatoid arthritis, and it's a recombinant protein that binds the IL-1 receptor, and it competitively inhibits the IL-1 pro-inflammatory cascade, which is very broad reaching, and it is important for promoting cells of the innate immune system, such as neutrophils, eosinophils, basal cells, mast cells, and natural killer cells. It's also important in the CD4 T cell response, mainly the CD4 Th17 type response. And similar to the downstream effects that we just noted with monoclonal antibodies that affect Th17 type polarized T cells, patients on IL-1 receptor antagonists are at an increased risk of upper respiratory infections, sinusitis, otitis media, nasopharyngitis, cellulitis, pneumonia, as well as bone and joint infections, as well as fungal infections, including histoplasmosis and candida, and mycobacterial infections. I hope you're starting to sense a theme here that these patients should also be screened for tuberculosis, and live vaccine should be held for these patients. So today, in brief, we went over the immunomodulatory effects of glucocorticoids, monoclonal antibodies, and some monoclonal antibodies, certainly not all of them, and some recombinant protein as well. And we can use these cutting edge treatments to dampen the immune response in the setting of chronic inflammatory diseases. But it's important to remember that our patients may also suffer the consequences of increased risk of infection. We can mitigate some of these risks with screening, vaccination, or prophylaxis, and we can also have a heightened awareness for infection in patients on immunomodulatory therapy. So our take-home points today are that patients on immunomodulators are at an increased risk of both common and severe infections. And please have a heightened sense of awareness for infection in patients on immunomodulators, as you remember that they may not exhibit the same signs and symptoms of infection as those with intact host immune responses. And do not hesitate to consult infectious disease if you're concerned about infection in patients on immunomodulators. Prior to the initiation of an immunomodulator, you should consider if screening is indicated, particularly for hepatitis B virus or tuberculosis. And then you should consider PJP prophylaxis in patients on glucocorticoids, and especially on those patients on glucocorticoids in combination with other immunomodulators, or as we discussed earlier, in patients with an underlying impact of their underlying disease on their immune response. If you're interested in this topic, I suggest that you have a look at the Immunomodulators, chapter number 49 in Principles and Practice of Infectious Diseases. It was written by some of the folks here at University of Washington and gives an excellent overview of the infection risk associated with some of the immunomodulators we talked about today. And then there's also a few areas of the literature that I found particularly helpful. One is the rheumatoid arthritis and rheumatology literature, and the other is the GI literature touching on ulcerative colitis or Crohn's disease in patients who are on immunomodulatory therapies. All right, I am happy to answer as many questions as I can about immunomodulators. I'm certainly not an expert, but thank you for listening, and I'll give it a shot.
Thank you so much, Sally. That was such a great presentation. I learned so much. I'm going to go through some of the comments and questions that are in the chat, and then I'll maybe open it up to if anyone wants to unmute themselves and ask questions.
Sure.
There was one question or comment that came up. I wonder why PML is associated with so many of these agents. Any comment or thoughts on that from your end?
You know, I think that PML in general is not well understood, but it's a disruption of the immune response. And as you've seen here with especially with glucocorticoids, but with many of these immunomodulators, there are so many downstream effects of them that we just don't have a great understanding of. So I think I probably could delve into that a little bit further, and I think somebody should do a little more research on it, but I don't think we have a great answer to that because it doesn't seem to be particularly associated with one class. So it doesn't make a lot of immunomodulatory sense to me.
Thanks. And then there was a back and forth that I'll just call out in case anyone doesn't have access to looking at the chat easily. A question was posed: if someone screens positive for TB, do you delay starting their treatment until they complete treatment for their TB? And Kevin Blau just encountered this situation on ID, completing 1 month of TB treatment. And then some follow-up that patient is doing well.
Cool.
And then another question came up, should we empirically treat patients for strongyloides from endemic areas before starting them on anti-IL-5 therapy?
I don't think there's any indications to say that we should empirically treat, but you can test for strongyloides, and you should consider that if you're concerned, because there is an increased risk. And I would certainly take that one very seriously, because that hyperinfection syndrome can be fatal.
Great. And then another question, as you were researching, did you find any good resources for looking up the infection prevention and pre-treatment screening considerations for different types of therapies?
No. So the American Association of Rheumatology, American College of Rheumatology, has a few guidelines for some of these. They mainly center around TB, and then a few things about hepatitis B. And then the American Association of Liver Diseases has some good guidelines that specifically are associated with hepatitis B virus and hepatitis C virus. But in general, there's not one great source that pulls all of this together, which is why I found this particularly frustrating, but also very interesting. I had to go to a lot of different aspects of the literature in order to pull together some of this. The chapter that I mentioned actually does pull a lot of it together, but it doesn't have specific guidelines. There's a little bit of mention of guidelines in there, but nothing cohesive of like a tick box of I'm going to start my patient on this and I need to do these things. I suspect that some of that probably is in the drug company insert stuff, but I've never actually looked.
Great. And then a question specifically about anakinra. Are these infectious risks also increased for patients getting short-term anakinra for gout?
That's a great question. I don't know. I suspect that at least somewhat they are, because it is a pretty broadly acting interleukin, and so it has pretty rapid effects on the immune response. But I don't know about short term. That's a great question. I should look that up.
And then just a comment to call out that John Cho put in the chat, that there are some resources for immunomodulatory agents and how they should be treated around the time of elective surgeries. And so he put a link to a paper that's often cited for some guidelines from the 2017 American College of Rheumatology guidelines.
Awesome. That's very helpful. Thank you.
And then another question, are there any different recommendations for HPV screening or risk assessment in patients on immunomodulators?
I'm going to steal from later in the chat here. I see that Becca just came off of a women's health elective. That's very helpful, Becca, that basically you should discuss starting annual PAPs and HPV testing with patients who are on immunomodulators. And again, we do know that increases risk of infection to many of these increased risk of infection or sequelae of viral illnesses. So that makes complete sense.
Great. I'm happy that you beat me to that. And then just a lot of other compliments and praise. Anyone else with any other questions, feel free to unmute yourself.
Aiden, does that include those on steroids? I don't know, Aiden. Becca, do you know? Sorry to call on you.
I don't know.
You don't know.
Sorry.
That's okay.
We were like, if you're unsure, just call GYN, they will tell you.
Perfect. I definitely would say also, if you encounter these patients in an inpatient setting and you're concerned about the effects their immunomodulator is having on their hospitalization in any way, shape, or form, I would call rheumatology, because these are really complex. And I had to continue to narrow this topic down, and I certainly didn't touch on nearly half of the information that's very disjointed and decentralized out there about immunomodulatory treatments.
If there's no other questions, thank you so much, Sally.
Cool.
I think you did such a wonderful job synthesizing a really complex topic.
Thank you, guys.
Before we jump to break, I hope Ryan or Izzy or Alice are available. I'm going to give the now virtual podium to one of the three of them to talk a little bit about the new health equity pathway, and I'll let them do the introduction. Whichever one of you wants to speak, you're welcome to.
Yes, I'm here. Hi, thanks, Courtney. I appreciate that. Just want to take a quick 30 seconds to everyone to encourage them to fill out the Health Equity REDCap survey that was sent out last week. And I appreciate those who have filled it out so far. I don't want to bias everyone's results, but we're hoping to use this data to build health equity curriculum into our program in multiple different levels, including a pathway that myself, Izzy Westling, and Alice Manos are working on, along with some of the program leadership and APDs. And we also hope that some of the other groups on campus, including the RDC, will use this information to guide other levels of curriculum as well in the coming future. So I can drop the link in the chat, and it also should be in your emails as well. So thanks in advance, and stay tuned.
Great, thank you so much, Ryan. Okay, now we are time for a break. We've got a couple minutes added. Why doesn't everyone take an 8-minute break, and we'll get started back at 9:50.